Uh, Hi, everybody. So I just wanted to share with you guys a lovely ECG that I received recently. And it's quite an interesting one. It had actually come through from one of our doctors at local district hospitals. And it's just an interesting one and one that you can learn quite a bit from. So when you look at this initially, it might seem a bit scary, but once you break it down, it's actually not that bad. The only thing I don't have here is a good rhythm strip, which we didn't get from this, but otherwise we'll just carry on and just try and figure out what's going on. So the first thing is, I mean, as with most of these patients, they do present with centralized chest pain and not feeling well. And in fact, this patient, what had happened was the patient had severe pain and it actually improved and then felt better afterwards and went to the hospital just to check and see what exactly was going on, to see if there was something else that was happening. It actually turned out that he had quite a serious complaint. Those of you who have been following the channel for quite some time and following the group for quite some time may already be picking up what's wrong, but for those of you who don't, we're going to go through it now. So we're going to go through it just step by step, and we're going to have a look and see. So we're going to look at the axis first. So the axis, we notice that lead 1 is primarily negative and lead AVF is primarily positive. So we're actually leaning into the right axis now. So once you start getting into the right axis, then it tells you one of two things. Number one, either the right ventricle has become larger or the left ventricle is damaged. So it's one of those two. So if we look at the rhythm, in this case, what we would have noticed is that we actually don't see P waves when we look through. And that's why it would be nice to have a full rhythm strip to actually be able to see if there were P waves that were hidden. But in this case, there were actually no P waves that I could find when I looked through the thing. There was a query and argument, was there one there? Was there one there? But overall, it really doesn't look like there's a P waves at all. So already you can say, listen, the atria are not functioning properly. And we'll get into why in a little while. So we don't have P waves. This is a junctional rhythm because we've got narrow QRS complexes. We can't talk about a PR interval or QRS following every P, but we can see that the ventricles are receiving their input from something above them. In this case, it's not the SA node because there's no P wave. So that would imply at the atrioventricular junction that there is something, there is an, what you might call it, an extrinsic pacemaker node, pacemaker cells that are actually providing this. So that's why we get this rhythm, right? And then if we look at the rate, we've got 1, 2, and so it's just above 100. So this is actually an accelerated junctional rhythm, all right? Or it's not a junctional tachycardia. Junctional tachycardia is generally when it goes over 120, but it is fast. It is fast. And junctional rhythms have their own nomenclature. So you get junctional bradycardias, junctional rhythm, then you get accelerated junctional rhythm and junctional tachycardia. So this is a junctional, accelerated junctional rhythm. Okay, so are they regular? They're not regular, but this can also be put down to sinus arrhythmia because it's not that there's a particular abnormality with the rhythm besides the P waves being absent. So these little variations here could be put down to sinus arrhythmia. Now we get into the meat of it, where we're going to start looking at each of the areas, each of the zones, and this is where we'll start really picking it up. So first we're going to have a look at the inferior zones. So what leads 2, 3, and AVF. And the first thing that we notice is that we've got a bit of ST depressions and a very prolonged QT interval. So the prolonged QT interval can be due to infarction. Most commonly, it's due to electrolyte abnormalities. There's also, once you study the variations of the ST segment, as we call it, you'll actually find that this actually has to do with the repolarization of that ventricular wall that there's a problem. But that's quite advanced. I don't want to get into that right now, but it just shows that there's actually an issue with the ventricle trying to contract. So its initial contraction seems to go well, and then after that, it's struggling to get its entire wall to contract after that. So that's where we have a bit of an issue over there. But nevertheless, we can see an ST depression. If we go to the septum, all right, or the, let's say V1 and V2, all right, here we can see an ST elevation in V1. So that would point towards possibly maybe something happening on the right-hand side. But once we come to V2 and then V3, V4, V5, V6, we start seeing all of these ST depressions that are present, you know, so there's quite a few ST depressions, and it's even present on 1 and to a certain extent on AVL. So there's elements here of quite a few things. Now, what we've got, and you know, it's a hemiblock. That's one of the things. So some of the fibers, you know, running to the left ventricle have been damaged. This would imply that the left ventricle is not working to its absolute best, and that's why we're starting to see a right-sided shift in the axis. We know that we've got atrial abnormalities, so our SA node has been taken out, and most likely due to whatever is going on. Now, at this point, this is where we get to the forgotten lead, which is AVR. So AVR, looking at that side, we see ST elevations. And once you see ST elevations, this is a main stem infarct, or the proximal left anterior descending artery has been blocked. Now, this we've covered many times before, but this was a nice example of an actual patient who had come in and who had this problem. So even though we've seen it before, we can now see that the history does match what's being told to us. So this patient had severe pain. This patient had severe pain because they were experiencing an infarct. The infarct affected the atriums, so we have no atrial function. The infarct then affected the left ventricle and causing a hemiblock. Now, even though it's proximal, there may still be some blood flow going through. So we may, for example, have the circumflex, anterior circumflex that may be getting some blood going through to it. There may be some collateral circulation, and that's why we're not getting a complete left bundle branch block. And that would explain why we're seeing this pattern that we are seeing that almost looks like a left bundle branch block, except for the fact that we've got narrow QRS complex. But if you were to look at this, if this was, for example, in V5 or V6, we would say that it's a complete left bundle branch block. In fact, here in lead 1, you would argue that that could well be a left bundle branch block. But in fact, what we've got is a bit of a hemiblock. Now, what's going on is that this patient initially has the blockage, the pain becomes quite severe, and then because of denervation of the nerves of the heart, the pain then quickly subsides. Because there's lack of blood flow to those nerves immediately shut down. So the patient is no longer feeling pain. Similar to a diabetic with neuropathy, you know, it's just that in this case, the neuropathy is caused by the infarct itself. So the patient actually feels better. But when the patient comes in and you do the ECG, you might be tempted to say, okay, this may have been an NSTEMI, which is what it looks like. I mean, if you really just looked at it at face value, it would look like an NSTEMI, because you've got your anterior, your laterals, and your inferior sections all showing these ST depression. So you would say, okay, this looks like an NSTEMI, but when you have a look at AVR and you see that ST elevation, that should prompt you to think, no, this is actually a proximal LAD occlusion, and that's what's going on over here. So this patient here, unfortunately, did not do well. The occlusion was quite severe. The patient ended up in ICU here. As far as I remember, having spoken to one of the medical specialists, did go down to Grays, but has not returned from there because there's quite significant ventricular damage that took place. So there wasn't much that they could do, because ideally you'd want this patient to have a PCI, percutaneous coronary insufflation. They don't respond well to thrombolysis. thrombolysis. Now, they did try thrombolysis here, but it didn't work. The patient showed no signs of reperfusion, so they did send the patient down to Grays, and the patient then apparently went for PCI, but is not doing too well, the last that they had heard, So these patients are very prone, especially when your atriums are out of it. There's a possibility that it can, of course, occlude more, and then you've got a patient now who's going to become bradycardic, hypotensive. There's quite a bit that goes on. But for us in the emergency department, the important thing to know is diagnosis, quick diagnosis. So if the patient had come in, presented, especially patients who present with severe chest pain that subsides suddenly, you've got to think of a proximal LAD. Now, it's not to say this will happen every day. These are the types of patients that you see maybe once every 2 or 3 months. It's not a common thing, but it does happen. And when it happens, this is the type of picture that we actually get. We had a patient recently who has actually who demised following an upper GI bleed, but the upper GI bleed actually aggravated a pre-existing proximal LAD occlusion, and the patient then demised. And on the ECG from the resus, you could see he developed an acute infarct secondary to the blood loss, and that was quite an interesting case that I think we've discussed it, but I'm not sure. So this is just how you would look at this. Now, if you were the problem with this is if you diagnose it as an NSTEMI, your treatment is completely different from a STEMI. This patient needs urgent transfer, urgent PCI, urgent management, as compared to an NSTEMI, where you're still going to do your enzymes, you're still going to have a look, you're going to repeat your ECGs, and you're going to see what's going on. So always remember, don't forget AVR. Have a look at AVR. Make sure there's no ST elevations over there. So we've covered quite a bit. We've got an accelerated junctional rhythm. We've got a hemiblock, plus we've got a proximal LAD STEMI. And in the emergency department, you can start these patients on the usual treatments. They do respond quite well, but unfortunately, they don't respond well to thrombolysis. Okay, so I hope you guys learned something from that, and we'll try and have another one soon. Thanks. Bye.